Dr. Omid Bendavid, welcome to the podcast.
Thank you so much for having me.
Thank you so much for being here. I know you're a busy man, and you're actually going to get a lot more busier soon with your upcoming twins. So,
Thank you.
congratulations on that.
Thank you so much. Appreciate it.
I'm so grateful that we're here today to have this conversation because breast cancer is a topic that is really important for women to be educated on. And not only women, but men, because every man has a wife, a mother, a daughter, a sister. So it's really important that we are all educated on the topic as a whole. And I was doing my research to prepare for this episode, and I realized how much I actually don't know about breast cancer. And I'm sure there are a lot of women out there who feel the same way because unless you've had it yourself or someone close to you has been through it, you really don't know all the nuances and all there is to know about it. I read a really staggering statistic that breast cancer is the second leading cause of cancer death among women in the United States, second to lung cancer. And I was shocked to read that because it's one of the few cancers that we're actually routinely screening for. So, why is it that we can't prevent more women from succumbing to it?
Yeah. So unfortunately, breast cancer is more common than we think, and 1 out of 8 women in their lifetime will actually have breast cancer. So
Wow.
that's about 12.5% of the female population. So it's something common, and it's something that almost everybody has either a family member or friend that has been affected by this. So it's, very important to be educated on this and know what steps you can take to screen yourself or try to maybe help lower your risk of developing this. And we will get into all those things later in the interview. This is one of the reasons why I chose this field. And I had people that were close to me that were affected by this during my training. And I saw that there was a big need for this. There weren't enough breast imaging experts in the community or as in a whole. And dedicated my career into going into this and providing the best care possible for women out there. So this is something that's close to my heart and something that I've dedicated my entire life and career towards.
Yeah, thank you for that. I mean, you hear about the women who do their due diligence, they get their mammograms, they feel like they're checking all the boxes, they're doing all the right things, yet they're still diagnosed with breast cancer. Let's start with the basics. At what age should you start getting mammograms and how often?
So for women that's average risk, the current guidelines from the American College of Radiology and the American Board of Gynecology and Obstetrics recommends screening mammograms starting at age 40, but that's for an average risk individual. If you have risk factors, whether it's family history or genetics or other things that may cause you to be at a higher risk, then screening can start as early as 30, sometimes
Wow.
even earlier. But in the United States, for an average risk individual, we start at age 40 and then we do it annually. So once a year.
And do you find that women are getting breast cancer in their 30s?
Unfortunately, yes, but it is mostly secondary to, since normally women are not getting screened in their 30s unless, like I said, they have higher risk factors. We don't see these individuals. So a lot of times,
Mhm.
if we do catch someone in their 30s with a breast cancer, it's because they're coming to us of a new symptom. Usually it's a lump, could be focalized or localized breast pain, skin thickening, nipple discharge. There's different symptoms that they can present with. But typically, we're not screening individuals in their 30s unless, like I said, they're higher risk.
Mm.
So those patients are usually coming to us with symptoms, whereas people that we screen in their 40s are usually asymptomatic. But since we have a screening program in place, we're catching up. We're catching a lot of these cancers before they are symptomatic, and that's one of the best prognostic factors of how patients do long term is finding these cancers when they're small, because the treatment and prognosis is far better than someone that we diagnose after it's become symptomatic. Those patients can still get treated, and most of the time they do fine. But the smaller it is before it even becomes symptomatic is the goal. And that's the whole
Yeah.
goal of the screening program.
So would it be safe to say that if you have any family history, just get a mammogram at 30, just get your baseline, just find out sooner than later?
It depends. It depends on who the family member was, what age were they? Was it a first degree relative? First degree relative meaning
Mm.
mother, sister, or daughter, and were they premenopausal? So If I have a patient that asks me, hey, when should I get screened? And they give me their family history. Let's say they say my mom had breast cancer at age 45. Typically, the recommendation is that we start 10 years prior to the age of diagnosis of that first degree relative. So if the
Okay.
mom was diagnosed at 45, we don't wait for the patient to start their screenings at age 40. We have that patient start at age 35. Or if they tell me that their sister was diagnosed at 40, then this patient will start at age 30. So we start 10 years prior.
And what are the different modalities for testing?
So the gold standard to this day for screening is mammography, and that's basically using a low dose X-ray. We take pictures of the breast, and now we've shifted from 2D mammography to 3D mammography, which is a much more powerful type of mammogram. Pretty much the same amount of radiation, but it does a much better job of finding breast cancers, especially in more dense tissue. That's the gold standard. Usually we supplement that with a breast ultrasound study, which instead of x-rays, it uses sound waves. And that's something that we also frequently use on patients in their 20s and 30s. Since there's no radiation, we're not concerned about, giving x-rays to a younger population. And then the third modality that is approved for breast imaging is breast MRI. And that's a very sensitive test. And usually we reserve that for patients that are high risk, or we use it for problem solving. So if something is inconclusive on mammograms or ultrasounds and we need to still investigate it a little bit further, we can use breast MRI to help solve those difficult cases. But breast MRI is not for everyone. There's number one, it's very limited. Not every place has it. It uses contrast. And so patients have to get injected with a gadolinium. And so it's an invasive procedure. And then on top of that, you have to go into this big machine that looks like a donut and you're laying in there. And so some patients are claustrophobic
Yeah.
and can't handle it. But having said that, most patients end up doing fine, which is mammography and ultrasound or the combination of the two, and they won't need MRI for additional screening. But those are the three mainstays: mammography, ultrasound, and MRI.
And are the 3D mammograms now standard?
Here at my practice, that's basically all we do is 3D mammograms, and most insurances now cover that. I remember when it was first introduced maybe 10 years ago, maybe 5%, 10% of insurance companies said they were doing it. And as time has gone on and they've seen how many more breast cancers and how much earlier we can diagnose breast cancers in patients, it's almost become the standard at most places. There are still some places where you go, and I'm very surprised, where they don't do it. They don't offer it. They don't even have the machine for it. So make sure if you are getting a screening mammogram, make sure it's a 3D tomosynthesis mammogram. The one that we use here at my office is a second generation, which is even higher definition, and it's the most state of the art that is out there right now. And it's the difference is night and day when you look at ones that are 2D versus first generation 3D and second generation 3D. There's a big jump from each one.
Well, especially if insurance is covering it, there's no reason to get the 2D at this point.
Absolutely.
And you had mentioned to me earlier that 50% of women have dense breast tissue.
Correct.
So if you fall into that category, you get your annual mammogram, it comes back negative. Should you then consider an ultrasound? And if so, how often should you get the ultrasound?
Absolutely. So breast tissue ranges from fatty tissue, which makes it very easy to be able to see through the breast, all the way to dense tissue on the other end of the spectrum, which everything looks white, and it makes it very difficult to find uh, things on mammogram alone. And so the more dense your breast tissue is, like you said, 50% of patients fall into that category. It makes it more difficult to be able to find everything on mammogram alone. So we add ultrasound, and I recommend it for all my patients that have dense tissue. If you have dense tissue, get the ultrasound because it really helps us see through that dense tissue. The analogy I make for patients is imagine driving on a clear day versus driving on a day where there's thick,
Mm.
dense fog. You can still drive, but your visibility is limited. There may be a red light a block ahead of you and you don't see it. Whereas, you do the ultrasound, imagine like a big gust of wind coming and blowing that fog out of the way, and then you can see things more clearly. Having said that, patients then say, okay, well, if I have dense tissue, why do I even need the mammogram? And it's important to remember, the ultrasound is not a replacement for the mammogram. The mammogram is still the gold standard, still shows us some of the earliest forms of breast cancer. A lot of times it'll show us little microcalcifications, which could be the start of a breast cancer. And that's something that's not seen or appreciated on ultrasound or MRI. It's only seen on mammograms. That's why mammograms are still the gold standard and the modality that picks up the most number of cancers, even if you have dense tissue.
Okay, so I actually fall into the category of dense breast tissue, and insurance does not cover the ultrasound. Should I have the
Unfortunately,
ultrasound every year?
you should. You should have it every
Okay.
year. You could either do it at the time of your mammogram, you get your screening mammogram done, and you go right into it and get the ultrasound done. That way the radiologist has, your same day exam and can correlate, things. If they see a little nodule on your mammogram and then you go into the ultrasound and they see that at that same location you have a cyst, then that's nothing to be alarmed about. But they can make the correlations on the same day. Or some patients want to do it every 6 months, and so they stagger it. So they come in, let's say, every January for their mammograms, and every July they come in for their ultrasound. So someone's looking at their breast every 6 months.
Oh, I like
You
that. That's actually a good idea. So
you
you
could do it
yeah,
yeah, you could do it any way you want, but I would recommend, at least if you have dense tissue, I would recommend at least doing one of each every year.
okay, I'm
And
gonna
like
add
you
that to
said,
my list of things to
yeah,
do.
yeah. So like you said, a lot of insurances don't cover it, or they cover it partially. Some insurances cover it 100% because you do have dense tissue and it's been documented. But there's states that are passing laws saying that you have to be able to offer patients ultrasound, uh, and and I believe that the insurances in those states will cover it 100% if you have dense tissue. I think that's, it's just a matter of time where it's going to become a standard,
Yeah.
and we're mandated by law to let patients know they have dense tissue, and that's across all 50 states. But patients need to know where they fall, if they have dense tissue or not, and if they do, they should be getting a breast ultrasound study. And I mention it to all my patients.
What do you say to people who are apprehensive about radiation exposure and it deters them from getting all this testing or additional testing?
So, the amount of radiation you need is minimal. It's a low dose mammogram is what we use,
Okay.
and you have to remember, like, someone getting a CAT scan is getting thousands of times more radiation than someone getting just a mammogram. The amount of radiation that you're getting in a mammogram is about equivalent as jumping on a flight, flying to New York, flying back. You just got as much radiation
Yeah.
as a mammogram. And we're not doing the mammogram for you every single week. We're doing it for you once a year. And the risk benefits of getting the mammogram far outweigh any potential risks of getting something bad from the mammogram and potentially missing a breast cancer. So you have to remember, it's a risk benefit, and the amount of radiation is very, very low. And we have to remember that we're constantly surrounded by radiation. We
Yeah.
don't talk about it, but going out and laying out in Santa Monica Beach for a few hours, you just got radiation. Getting on a flight, you got radiation. Living in a place like Denver, Colorado, you're getting radiation just from the earth.
Yeah.
So we're constantly surrounded by it. People don't talk about it, but because it is a medical device, we have to disclaim, we have to make that disclaimer and let patients know that there is a small amount of radiation involved.
It makes absolute sense. So I'm 43 now. I've had 3 mammograms and my
You're right on
most
schedule.
I'm on schedule. I've been really diligent. But my most recent mammogram, they had me do a little quiz before my appointment. And they were basically assessing my Tyrer-Cuzick score. And I've only come to know about what that is recently. And I want to stress the importance of knowing the score. I think there are probably a lot of women out there who have never even heard of it. Can you tell us what the Tyrer-Cuzick score is and how we can find out our score?
Yeah, absolutely. So the Tyrer-Cuzick is basically a risk assessment calculator. We actually have it on all of our intake sheets as well. And basically, it takes into account like your age, your height and weight, or BMI, your race, your ethnicity. If you have Ashkenazi Jewish heritage, it asks you what your breast density is. Are you dense or not dense? It'll ask you questions like, how old were you when you had your first baby? Were you below the age of 30? Or were you above the age of 30? Are you premenopausal, perimenopausal, postmenopausal? If you are menopausal, at what age were you? Hormone replacement therapy. Have you ever had any previous breast biopsies? Have you ever had genetic testing? Are you BRCA1 or BRCA2 positive? Any other types of breast cancer? Family history of breast and other types of cancer? You answer these questions, it'll spit out a score at the very end. If you score below 15%, you're at average risk. Like we discussed earlier, 1 out of 8 women will develop breast cancer in their lifetime, which puts you at 12.5. But below 15 on the calculator is considered average risk. 15 to 20% is considered intermediate risk. And then above 20% is considered high risk. And basically what that tells you is that you need to be a little bit more diligent as far as your screening. Like, just don't go get the mammogram and go home. You may need extra imaging. For example, like we discussed earlier, especially in lieu of dense tissue, you should be considering getting breast ultrasound. And for some of these high risk patients, they would actually benefit getting a breast MRI in addition to getting their normal mammograms or ultrasounds. And so it's a powerful tool. And just like how you know what your age is or what your weight is or what your height is, I think women should just know what their Tyrer-Cuzick score is or TC score is, or also known as IBIS. So it's something that more and more places, either the OBGYN will calculate that for them, or a good breast imaging center will also do that for them.
Is there like a website they can just go on and just figure out their
Yes,
score?
You can just Google search Tyrer-Cuzick calculator, and there's a bunch of websites you can go to, and it's all basically the same type of calculator.
Okay, so I just want to stress the importance of every woman knowing that score. Just like you know your weight and your height, you need to know that score. I will say that one of the questions you mentioned was the BRCA gene, the
Correct.
BRCA1, the BRCA2 gene, that it asks if you have been tested positive for that. I actually didn't know the answer to that. I realized I've never tested for it. I always assumed that when I was pregnant, I did all the genetic testing I needed to do. I've later come to find that I actually don't know if I'm positive or not. So my question is, where can I actually find out whether or not I'm positive for this gene? And if you are positive, what does that mean?
Yeah, so testing for it is actually pretty easy. They can do it with either a blood test or a saliva test. You can do it in your OBGYN. Most OBGYNs will offer that for their patients.
Okay.
They basically send out the specimen. They'll quickly run the screen and tell you if you're either a carrier or not a carrier, and if you are, if is it for BRCA1 or BRCA2 or both. And sometimes they'll let you know that you are not a carrier, but you have a variant, and so that also falls into a high risk category. And so if that is the case, then you get set up to be seen by a genetic counselor. And then the genetic counselor will basically kind of go through what steps you need to do because the gene is associated with a high risk of not just breast, but ovarian cancer. It'll tell you that, you need to get screenings done for your breasts, for your uterus and ovaries, and at what age you should start and what things should you be doing if you haven't done it already. And for patients that are super, super, super high risk, let's say it comes back as, they're positive and they have a strong family history, and they also have a super high Tyrer-Cuzick score. Some patients may even opt to undergo prophylactic mastectomies, or they may want to go undergo a total hysterectomy just because they're like, you know what, had my, let's say, two children that I've wanted to have. I'm not, I'm not I'm not trying to have any more children, or I'm not trying to breastfeed anymore. And if these are things that, in my lifetime, I have a 75%, let's say, risk of getting breast cancer, and I'm 45 years old right now. And if I don't need my ovaries or uterus, these are things that I can consider as far as having removed. But that's a very personal
Yeah.
decision to make, and that's something that needs to be made between the patient and the surgeon, and see if that's something that they want to do. But some patients will want to do that just to basically so they don't have to worry about it and don't have to keep getting screened every year for those things, and for peace of mind, saying that, you know what, I don't want to constantly be in fear of, is this the year that I'm going to get my breast cancer? Is this the year that I'm going to get my ovarian cancer? And by prophylactically removing those, then they basically will live a relatively normal life. But that's something that's a personal decision, and it's not the decision for everybody, but it's an option.
Yeah, that's a tough one. I have a friend of a friend whose sister was diagnosed with breast cancer. She's in her early 40s, totally fine. And she's been advised by her doctor to get a double mastectomy.
Uh,
It's shocking to me that the BRCA test is not something that's introduced in our standard OBGYN appointments. I had never been asked if I have the BRCA gene. I'd never even been offered the test. Why is that not standardized?
I think it's more reserved for patients that we think are high risk, or they have some family history of breast or ovarian or other types of cancer. And so we're like, okay, well, patient either recently diagnosed, or a family member recently got diagnosed. I have patients that come to my office, I'm like, why are you here today? You're 32 years old. Like, oh, my mom just got diagnosed with breast cancer. She's in her 50s. My doctor just wants me to come in and just get a screening ultrasound study done. And I'm also getting tested for the BRCA gene. I'm like, oh, really? They're like, yes, because they tested my mom. She's positive. So now
Mhm.
that they know that she's positive, there's a chance that that may be passed down to me. So now I have to get tested. But if they had tested the mom and she was negative, the patient may or may not still get tested, but usually they don't test it because they're like, okay, your mom was positive for breast cancer, but it wasn't the BRCA gene. So don't worry about it.
But
One thing I wanted to just on the topic of this patient and her mom having breast cancer and things that patients ask me is that, they come to my office and they're like, hey, doc, there's nobody in my family who had breast cancer. So there's no way I'm going to get it. Right. And that's a common myth because only 20% of breast cancers is there a family history.
oh,
80% of
wow.
cancers, there's no family history. So that's a common myth. Patients coming in saying, hey, doc, I'm good. Like, why do I need a biopsy? There's nobody in my family that's had any type of cancer. Well, that's good. That's good news to have. But mind you, only 20% have positive family history. Not 80% of them do not have a family
Wow.
history of breast cancer. And
I
on
did not know that.
the topic of genes, we talk about BRCA1 and BRCA2. There's a bunch of genes that they know about. So there's the famous ones are BRCA1 and BRCA2, but there's other ones like TP53, CHEK2, ATM, PALB2. There's all these genes that we know about now. And if you add up all these genes together, all of these genes that we know about together, it only accounts for 10% of the breast cancers.
Wow.
So 20% have a family history, 10% have a genetic component. That adds up to 30%. So what about the other 70% of breast cancers that we're diagnosing? Where are they coming from? And so we have to think about the environment. We have to think about risk factors that may be involved.
That was my question. Like, what about lifestyle? What lifestyle changes?
Absolutely. Absolutely. I mean, listen, there's modifiable versus non-modifiable risk factors. Non-modifiable risk factors are things that you can't do anything about. Like you were born with dense breast tissue. Well, that's your genetics. You can't change that. Being a female, you're at a higher risk of breast cancer. You can't change that. Increasing age is a risk factor. You can't change that. Family history, these are things that you cannot change. But there are things that you can change that are called modifiable risk factors. And that's things like cutting out alcohol out of your diet, not smoking, maintaining an ideal weight, being physically active, trying to eat healthy. All these things are things that you can do to not just reduce your risk for breast cancer or any type of cancer, and just being more
Yeah.
healthy in general.
I love that because, I have the train of thought that we can't control everything in life. We
No,
can only control what we can control. There's a sense of empowerment, I think, and just in life in general, when you look at the things that you actually can control.
correct.
It can be really scary to think about breast cancer, and I didn't know that 80% are unrelated to family history. But if there are things that we can do, if there are things that as women we can control, why not do those things? It would give us a lot of peace that we can actually have some say in this process.
Absolutely. And one of the biggest factors that they've more recently have linked to breast cancer is alcohol consumption. And, we just find it so socially acceptable, commercials on TV and we want to meet friends or family and we have drinks, and whether it's religious or non-religious or celebratory or at a party or whatever, we find it so socially acceptable that we don't think of it as a risk factor. But, it's something that was recently categorized as a carcinogenic. When I was a kid, it was like everywhere I went, I saw people smoking. It was on TV, it was in
Yeah.
magazines. I would look at the billboards and you'd see the cool Camel, for Camel cigarettes, and the Marlboro Man, like a rough cowboy riding his horse into the sunset.
Or the hot woman with a cigarette.
Absolutely. And
Yeah.
it's like
Desensitized to those images.
we just thought it was normal.
Yeah.
Currently, I believe that's how it is with alcohol. We just find it so socially acceptable that we don't think about it. But now they've seen that it's basically dose related. I mean, the more
Mm.
drinks you have, the higher incidence or chance there is of you're going to develop some sort of cancer, not just breast, but any type of cancer. And so that's something that can very easily be reduced in your own hands
Yeah.
by cutting that out. And not just for cancer, but just wasted calories or, not getting hangovers. There's a lot of health benefits of not having it. Same with smoking, same with physical inactivity, just going to the gym a few days a week or going for long walks 3 or 4 times a week, doing a little bit of weightlifting. All these things add up over time. So, by doing these things in general, you're going to decrease your risk, not just for breast cancer, for any type of cancers, and
Yeah.
just overall, the less chance of disease, cardiovascular risk, heart disease, diabetes, back pain, joint pain, knee pain from carrying extra weight. All these things are just going to improve your quality of life.
Yeah, I couldn't agree more. I actually stopped drinking, I wanna say it's been like 2 years now. I mean, if I really wanna drink, I'll have a drink, but I just found that I don't need it as much anymore, and I really don't miss the hangovers, and I don't miss feeling crummy in the morning.
Exactly.
So, I don't know, I just think that if you can control one thing, one less risk, I'll take it.
In the same way, I rare occasions I'll have maybe a drink, but it's been more than a decade,
Yeah,
maybe
and you
more.
actually don't miss it. You get
I
used
don't
to
miss it.
it, right?
I don't miss it. I don't miss
Yeah.
it. I
So
enjoy having a non-alcoholic virgin drink just as much.
yeah, because sometimes it's like the oral fixation or it's just the
Exactly.
act of holding the
Yeah.
glass and being in that environment. So, if someone has a family history, are there any medications that someone can take to prevent or reduce their risk?
So they are. There's things like tamoxifen, which is like a estrogen blocker, which is the most common one. Typically, they put patients on a low dose tamoxifen for a number of years to try to suppress anything that could be associated with estrogen positive receptor. And so that's the main thing.
What are your thoughts on birth control? Does birth control increase our risk?
Birth control, very minimal.
I'm sure it's controversial.
It's controversial. It's a slight temporary increase if you're on it, but as soon as you go off of it, it just goes back to normal.
As far as the early signs of breast cancer, I always just assumed that it was a lump. You mentioned nipple discharge and pain. What are some of the other early signs?
Obviously, lump is the big one. So if you feel a new lump in your breast, that's something that needs to get checked out immediately.
Is it pretty obvious? Like, does it feel like a little marble?
It could feel like a focal area of thickening, like the area just feels more thick than normal.
Mm.
It could feel like a discrete lump. It could feel like a pea. It could feel like a marble. It could feel like a rock underneath the skin. A lot of times there's no pain associated with the lump. And so, if you feel a lump, it's got to get checked out. Pain, usually, not always, but usually it's fine. Usually it's hormonal or maybe caused by something like a cyst or a ball of water in the breast that can
And that's
cause that pain.
benign.
And that's benign. A lot of times pain is just physiologic. And if the patient tells me it's diffuse, it's on both sides, it's intermittent, or it comes and goes based on where they are on their cycle, that's just physiologic changes and that's normal. However, if they tell me it's more localized or it's just in one spot, then that's something that typically we have to work up and see what that's being caused by. But like I said, even when we do that, usually it ends up being fine. It could be something structural like a cyst. Um,
And so that leads me to, yeah, the importance of self breast exams, right?
Absolutely. And so other things that we look for are skin changes. Like if there's an area on the breast that all of a sudden the skin looks different, either it looks
Mhm.
more porous or it looks thickened or it looks red or it looks just anything that just doesn't look normal for you. uh, Nipple discharge. If all of a sudden you see that either one or both nipples are having discharge, especially if it's bloody or if it's black, or dried up blood, it needs to be checked out. There's different colors, it could be green, white, clear, yellow, red, maroon, brown.
Oh,
And
wow.
each one of those things can be more suspicious or less suspicious depending on what color it is. But that's something that needs to get checked out. Nipple retraction is never normal. It needs to get checked out. What else?
Like an inverted nipple?
Inverted nipple. Well, it depends. Some patients will come and tell me that, hey, I noticed that my nipple is inverted, but as soon as they squeeze the side of the nipple, it just pops right back out.
Yeah.
That's an inverted nipple. Usually that's fine. However, if the nipple goes in and no matter what you do, you can't get it to come back out, then that needs to get checked out immediately. Other things that we look for is crusting or flaking on the nipple of surface of the nipple. Sometimes that could be associated with Paget's disease. Going back to lumps, the other thing that we look for is not just a lump in the breast, but you should also be checking lumps for underneath your arm because sometimes those can be swollen lymph nodes. And so there may be a small cancer in the breast or one that you can't feel, but it's already spreading and going to those lymph nodes. And so all of a sudden, the patient will feel some lymph nodes that feel swollen or enlarged. And it's because of something in the breast, or it may just be independent of that. It may just be completely something different. But that's something that also needs to get checked out by a breast radiologist. But those are the big ones. It's a lump, pain, any changes with the skin, nipple changes as far as retraction or crusting or discharge. All these things need to be worked up and looked into.
And that just shows the importance of doing the self breast exams. I actually put a little reminder in my calendar. So I have this alert that goes off every 30 days. I can't say that I'm
Perfect.
perfect about it, but
That's
it
great.
just brings it top of mind because otherwise you just forget. And, just relying on your annual OBGYN appointment is not enough. You really need to do your part and do your self breast exams.
When you do the breast exams, the one thing I would recommend is things in the breast can fluctuate month to month on where you are in your cycle. So I'll always try to do it the same time.
Is there a better time to do it in terms of your
I would
cycle?
recommend doing it whenever it's least sore. So whenever they're not so tender and you don't mind pressing down on the breast, figure out when that's best for you, whether that's in the middle of your cycle or at the end of your cycle or the beginning of your cycle. But then once you do that and you kind of map out where everything is and you're like, okay, I have a little bit of lumpiness over here that always feels like that. I have a little bit of a lumpiness over here that always feels like that. Kind of have a roadmap of where
Mm,
things feel like and what's normal for you so that, when you check it every month, you're like, okay, no, that's the same area that always feels like that. And so you're
that's a
not
good
caught
point.
off guard. Because if you start doing it at different times of the month, depending on which parts of the breast become a little bit more swollen, then you may be like, "Oh, well, I didn't feel this last time, but it may be because you're on the different part of your cycle."
Yeah, that makes sense.
Yeah.
I want to talk about the different types of breast cancer because not all breast cancers are created equally. What are the different types?
So the most common is ductal carcinoma, usually invasive ductal carcinoma. That is the most common, but there's also lobular carcinoma. There's other more rare forms of breast cancer, like inflammatory breast cancer. Those are rare, but the bread and butter is usually invasive ductal carcinoma. Now, on that spectrum, there's also something called ductal carcinoma in situ, and that's commonly abbreviated by DCIS. And what that means is there's cancer cells, but they're inside the milk ducts. They're not inside the breast tissue yet. So these are stage 0 type breast cancer. They're not even stage 1. Once it becomes invasive, then that's when it becomes a stage 1 or stage 2, depending on the size. But a stage 0, which means that it's still inside the milk duct and it has not invaded into the breast tissue, that's called a ductal carcinoma in situ. And it's actually very common. And one of the reasons why mammograms are so, so, so important, because that's something that's only seen on mammograms. That's not something that we pick up on ultrasound. It's not something that we pick up on MRI. And typically, if a little cluster of calcification deposits either pops up on someone's mammogram and it's new, we'll either have to monitor it and make sure it's not continuing to change. Or if it looks suspicious right off the bat, we'll do a biopsy of that. And if it comes back as DCIS, that's a stage 0 type breast cancer and it has to get removed. But those are the main things, or DCIS, then jumps to invasive ductal carcinoma, and then the other types of cancer like lobular carcinoma, which is more rare, inflammatory breast cancer, even more rare, and then things like Paget's disease, which is, only diagnosed maybe a dozen of those in my career, pretty rare.
And what are the different stages?
Like where I already alluded to, stage 0 is when it's still inside the milk duct and it hasn't invaded into the tissue. And so the stage 0 type cancer would be DCIS. And then once it gets to stages 1, 2, or 3, it depends on the size. Once it starts traveling, so stage 1, 2, 3 are all invasive and it depends on the size of it. And then once it gets to stage 4, it means metastatic. It means it's already gone to the lymph nodes. The reason that's important is the earlier we catch it, the earlier the stage, the higher the cure rate. And so that's the whole goal of mammography and why we want to pick these things up early. And that's the whole point of screening. We want to pick things up before the patient is symptomatic, because once it's becomes symptomatic and the patient feels a lump somewhere, it's already probably at a stage 1 or stage 2 or maybe even a stage 3. But if we can catch these things at a stage 0 or maybe stage 1, the long-term prognosis is far better than something that's already advanced.
So early is considered 0 or 1.
Early, it depends on the size, but yes, something that's stage 0 is something that's not even invasive yet. So the chance of curing that is very high because the treatment and outcomes are very good when things are caught at a very early stage. And we talked about patients complaining of what symptoms and signs to look for. But even before that, if the patient is getting screenings done on an annual basis and we're looking at everything very closely, we're finding things that the patient can never feel because it's so small. And that's the goal.
So when someone gets a mammogram and you see a tumor or you see it's a positive mammogram, what is the next step? Are you immediately doing a lumpectomy? What's the next step in the process?
So typically, let's just start off with the average person. They come in, and they come in 41 for their mammogram, and they had one last year, and last year's was totally normal, negative. They come in this year, they get a mammogram, and there's a new mass. Let's say that I look at the mammogram and there's like a new 1 centimeter mass in the breast. Well, what happens next is typically that patient's screening mammogram gets assigned to BIRAD 0, which means additional imaging is needed. And the patient usually has to come back depending on where you are. At our facility, we try to do everything the same day, but at a lot of other places, the patient has to come back on a different day. They do extra pictures of that area to try to see what the margins look like on the mammogram. And that'll give us a little bit more information of what we're looking at prior to the patient going to ultrasound. And then the patient will have an ultrasound done, usually right after the mammogram. That ultrasound will then identify and target that area and see what that looks like. Number one, is it something that's cystic? Is it water? Or is it something that's solid? And if it's solid, does it have benign characteristics or does it have suspicious characteristics? And so we look at the morphology, we look at the margins, we look at the shape, we look at other things that a breast radiologist is trained to look for. And we then deem whether this mass that we see is suspicious or not. If it's something that looks very, very benign, we can opt to give it a BIRATS 3 or follow-up. We'll say, listen, it looks very benign. It has so many benign characteristics that 99% chances is nothing. It's like a fibroadenoma or a benign tumor. And we're okay with following this in 6 months. Let's just keep an eye on it, make sure it doesn't continue to grow or change shape or anything like that. If the margins look abnormal or it looks irregular, right off the bat, we'll say you'll need a biopsy, and then we'll schedule them for an ultrasound biopsy. And that's something that we do here at the office. Breast radiologists will do that.
An
And
ultrasound biopsy, so
an
they're actually
ultrasound
removing a piece of the
actually
tissue?
So the patient will basically lay down on the ultrasound bed. We will make the area sterile. We'll give them some lidocaine or numbing agent at the area so they don't feel anything. Small needle will go in and grab some pieces from that nodule or that mass. We collect it. We put it in a little specimen jar. We send it off to the pathologist. And then usually within 1 day, 2 days, we'll get the results back. And the majority of these things will still end up being benign. But like I said, if there's a slightest inclination that there may be something funny about the nodule, we just do a biopsy to be safe. If it's something that comes back a high risk lesion, which means that it's not cancer, but it has abnormal cells in it, which could potentially flip one day, then that's something that has to get surgically removed. And so we'll set up the patient to be seen by a breast surgeon, and the surgeon will remove the area. If it comes back as a
Lumpectomy.
cancer, lumpectomy, or it's called a excisional biopsy, or basically a lumpectomy.
Okay.
If it comes back as a cancer, they're going to get a lumpectomy. Depending on what type of cancer it is, the patient may also need to get radiation, in which they use external beam radiation to kill surrounding tissue around the area that targets a specific area. Or the patient may also need chemotherapy, which is more systemic. And so they have to take medications to basically treat the whole systemically. They have medication that basically travels through the bloodstream and it affects the whole body. That's how women sometimes will lose some of their hair with that type of treatment.
Yeah, I was gonna ask you the difference between radiation and chemotherapy. So
Yeah.
radiation is like essentially shrinking it.
Radiation is more local treatment, targets a specific area. Chemotherapy is systemic and it travels through the bloodstream and basically it treats the whole body. There's indications where patients will need all three. They'll need surgery, radiation, and chemo. And there's times where the patient will only need two of those things, either lumpectomy and radiation, or they'll need lumpectomy and chemo, or sometimes they'll just need one of those things and they'll just get surgery and that's it. So that's all determined by the patient's breast surgical oncologist or hematology oncologist.
So two women can both have breast cancer and have totally different treatment options depending
Absolutely.
on what kind of cancer, what stage it's in.
Correct.
Yeah, there's so
Correct.
many nuances. That's something
And
that I realized.
yeah, and the treatment options have become more advanced as time has gone on, because not just is there surgery and radiation, but the chemo, in addition to chemotherapy, they're now using hormonal therapy, things that block estrogen receptors and block progesterone receptors. And there's all these different receptors that they check for when they check for a breast cancer, everything from HER2 to FISH to all these types of gene expressions. And they can really go in and target that. It's called targeted therapy. There's target therapy, immunotherapy, hormone therapy, in addition to the chemotherapy, but that's all determined by the hematology oncologist. And they're the experts on that.
And how fast is the cancer actually growing? If you've been told, okay, this is potentially cancer or this is cancer, Do you have time to kind of assess your options and kind of think about it and get a second opinion or a third opinion? Or is time of the essence and you need to move like by the day quickly?
It depends. It depends on what type of cancer we're dealing with. It depends on how aggressive it is. There's something that is called a modified Bloom-Richardson score, which is a scale basically from 3 to 9. And the higher the number, the more aggressive it is. And not just that, but the size of the tumor. It all depends. If someone that has DCIS, stage 0, that's let's say 5 millimeters, is going to be different that has an invasive ductal carcinoma, poorly differentiated, Bloom-Richardson score of 9 out of 9. That's already 5 centimeters, or 50 millimeters. That's 10 times the size of this. These two
Mhm.
people both have breast cancers, but one is a lot more aggressive than the other. And so it all depends. Some of these cancers grow very, very slowly over years. There will be minuscule changes over the course of years. And some of them are doubling in size every few months. And so it depends on what you have. And depending on what it is, you may have more time to, do research on it and shop around versus someone that is dealing with something that is large and aggressive. They got to get the ball moving. And
And the doctors will be able to tell you which of those is your
correct.
case, is the scenario for you. Okay.
As soon as I get that pathology result, there's a ton of information that will give us what it is, what's the grade, what's the stage, what are the receptors, all these things. And so the surgeon and the oncologist will work together and be like, okay, hey, before you even do surgery on this patient, let's try to shrink this down. I'm going to put him on this agent. I'm going to give him this blocker. I'm going to put him on this. Once it gets down to a smaller, more manageable size, then the patient will be more appropriate to go into surgery. So that's called neoadjuvant chemotherapy. And so sometimes patients will see the oncologist to try to treat these things and get them smaller. And once it's gotten smaller, it becomes a lot more easier to treat with surgery versus then doing it the other way around, going to surgery and then going to chemo.
Because when you see it on the x-ray, do you know exactly where it is?
Yeah, I mean, basically, when we do the mammograms, I could figure out if it's in the upper part of the breast, lower part of the breast on one view. And on the other view, I can tell if it's on the lateral part of the breast or inner part of the breast. And then we'll figure out what quadrant it is or clock face. And then on ultrasound, also, we'll know exactly where it is. We'll know what the distance is from the nipple to where it's located and where it is on the clock face. And we basically just use like a clock face.
Yeah, and I ask that because then you can isolate and minimize how much good tissue
Exactly.
you're removing.
So even on my report, I'll say that there's a 15 millimeter mass located 6 centimeters away from the nipple, and it's at the 10 o'clock position. So just from those landmarks, you're like, okay, it's at the 10 o'clock position. It's 6 centimeters away, and it measures this big in size. So you already know, without even looking at the pictures, you already have an idea of exactly where it is and how big it is.
When a woman hears the words, "You have breast cancer," everything else fades away. There's a lot of fear and there's shock and a lot of questions. What are some of the most important questions? I know we've gone over a lot of things, but what are the most important first questions she should be asking her doctor?
So once they get a new diagnosis of breast cancer, they need to be aware of what kind of cancer they have. At least they should know what it's called and where they stand, and if it's one area, two areas, if the lymph nodes involved, not involved. And usually they have an idea of that even when they come and see me. I'll be like, listen, everything else in your breast look good. Your other breast looks fine. I just see this one tiny area on this right side. Your lymph nodes on that side look good. So worst case scenario, if this comes back as something positive, it's a very, very tiny area. I'll try to communicate that with the patient even before we do the biopsy, so they kind of have an idea. But once they get the diagnosis, they have to follow up with their referring doctor. And that doctor, first thing they do is get them plugged in to either be seen by a breast oncology surgeon or a hemonc or a hematology oncologist. Those physicians will then dictate on what the patient needs to do next. Like we discussed earlier, do you need to go on some sort of a systemic therapy first? Do you need to go to surgery first? Is this something that's also going to require targeted radiation therapy? But they will then manage the patient. Once they get plugged in and see that doctor for the first time, they will go down the check
Checklist.
boxes. They'll be like, this is what we're doing first. This is what we're doing second. I also want you to have a consultation with this doctor. And then they work together and then they form a treatment plan so the patient can get treated in the correct steps. And that's it. As long as they don't miss their appointments, they do everything that the doctors tell them, the patients do fine. These days, the survival rate for patients is extremely high, in large part due to mammography, because we're catching these things earlier, which is great. But even if it is a stage 2 or stage 3, and it is a little bit more advanced, We have amazing treatment tools now that we didn't even have 10 years ago. Even with those patients, they still do really well, but they really have to follow what the doctors tell them and do as they say. I mean, I have had patients where they've had recurrence and had an area that was removed, let's say 10 years ago. And each year I've been looking at their mammograms and they look fine. Then all of a sudden, there's some new calcium that's developed near the lumpectomy site. And that raises my suspicion. I'm like, okay, that's interesting. She didn't have anything here before. Now she's developed this. She's had a known history of cancer at that area. And the type of calcifications that she's developed don't look like they're post-surgical in nature. Sometimes we'll see something called fat necrosis, which can develop at the lumpectomy bed, but these look different than that. So why don't we do a biopsy for this? Because I don't want to miss anything. And so we'll do the biopsy. It comes back as DCIS. And so I'll talk to the patient. I'll be like, when you had your surgery done 10 years ago, besides surgery, did you have radiation done at the area or chemo? And they'll be like, no. I'm like, really? Because your first cancer had DCIS in it. And I know typically for DCIS, they also recommend doing radiation at that area. She's like, yeah, the doctors told me to do the radiation, but I just didn't want to do it. And so what happens now is that 5 years later, 10 years later, this chance of recurrence followed. And there's no guarantees, obviously. I mean,
Yeah.
this may have happened even with the radiation. But, when patients sometimes decide to take their management in their own hands, or they think they know what's better than what's been tried and true, they may run into these situations. I had a celebrity patient a few years ago. I diagnosed her, a very well-known person. I diagnosed her. She followed up with her doctor. She actually met with the surgeon, a very well-known surgeon. He's like, listen, you need surgery. We need to get you in. And she's like, okay, let me think about it. 6 months later, I see her name come up on my list and I open up her study. I'm like, what? The thing that I biopsied last time is still there. And in addition to that, there's even a new mass next to it that's even bigger than the one I biopsied
Oh
that
my
wasn't there
God.
before. I'm like, what is going on? And I go in and talk to her, and she's like, I met with this doctor, and they told me if I drink this special type of green tea every day, and if I go to him 3 times a week and get acupuncture and, do all these things that I've never heard of, that the cancer is going to go away on its own. I'm like, honestly, that's malpractice, because not only has that area not gone, it's gotten worse. The area I biopsied got worse, and there's also a new area. And I actually ended up biopsying that new area that popped up, and it was a new type of cancer that was not even the same type of cancer as her
Oh,
previous.
wow.
But if that whole area had been removed 6 months prior, she wouldn't even be running into that problem. The good news is she ended up going back to that surgeon that I had referred her to. They did her surgery and she's doing fine now. But I just never will forget that.
Yeah, you need to heed the advice of the doctors and
Exactly.
and do the protocol.
It reminded me of Steve Jobs when they told him first that, he had pancreatic cancer, and he decided to do his own homeopathic
Yeah.
remedy and just didn't do what the traditional doctors were telling him to do, unfortunately.
My question actually was gonna be about remission. So if you're in remission, what does monitoring it look like going forward? Are you still just doing the annual mammograms? And what is the likelihood of it returning?
So with remission, it varies. It depends on how big or extensive the cancer was. It depends on what type it was. It depends if they did a lumpectomy or if they did a mastectomy for you. And so all these things vary. If the patient doesn't have breasts anymore, and let's say they did a double mastectomy, let's say there was a lot of disease on one side and there may or may not have even been disease on the other side, but patient opted for a double mastectomy, she technically doesn't have breasts anymore. And so we can't really do mammograms for them. We can do ultrasounds for them. We can do MRIs for them to monitor them. And some doctors are a little bit more aggressive than others and say, listen, I want you to still go and get your MRIs done once a year or once every other year. Some of them will send us the patients for ultrasounds and the MRIs, and we'll do the ultrasound of the reconstructed breast. There's also no guarantees that once the breast has been removed and you've gotten a mastectomy, that you can't develop breast cancer again. Because you have to remember, when they go in and take out whatever's on the inside of the breast, they can't just leave only skin behind. The skin will die off. They have to leave a tiny, tiny little bit of tissue behind that skin so that there's blood supply to the skin, and so the skin doesn't die off. So imagine like carving a pumpkin.
Yeah.
If you carve a pumpkin and you carve it all the way to where the skin is going to cave in and it's probably going to just turn brown and not survive. So you have to leave a tiny bit of rind behind
Yeah.
so that that skin can stay alive. Having said that, if a tiny bit of breast tissue that's left behind has a one or two cancer cells in there, and those cells start to double and multiply. It can happen. And I've diagnosed at least a half a dozen cases like this in the past where the patients had a double mastectomy or single mastectomy, and patients complained of a new lump in that breast. They've come to my office. I'm like, yep, you need a biopsy. And it's come back as cancer. And so it can happen. There's no guarantees. So it depends. I would say most patients that are in remission will stay in remission and they end up being cancer free, but there's every once in a while we'll
Yeah.
get one. I don't know what the numbers are exactly, but the point of that is once you get diagnosed and you get treated, it doesn't mean, okay, I'm not going to even look or touch or do anything ever again. Your chances are far, far, far less, but you still have to be diligent about doing, self exams, going to your doctor. If your doctor says, hey, I still want you to get an MRI done once a year, you should be doing that.
Yeah, I mean, whether or not you've had it or you haven't had it, I mean, even with that 80% statistic that 80% don't even have family history, it sounds like all women need to just be on top of it and do their due diligence, do the self-breast exams, know your Tyrer-Cuzick score, know if you have the BRCA gene. We have to be our own health advocates.
You're your number one CEO of your own
Yeah.
health.
Yeah, I absolutely believe in that. I want to shift gears to AI because I know that AI has been wonderful in medicine. And I'm curious how AI has affected the field of radiology and if it's been able to help early detection of breast cancer.
Yeah, absolutely. So AI, not just in breast imaging, but on all of radiology, it's been a very powerful tool, and I've used it extensively. We're actually bringing it here to our practice in the next couple months, and it's something that helps aid the radiologist and helping them find additional cancers or potentially find things that could have been missed. It's not a replacement for a radiologist. There's still the number one tool for breast cancer right now is still having a well experienced, fellowship trained breast imaging expert look at your stuff, because by no means is AI perfect. And it does a lot of unnecessary callbacks. It picks up a lot of things that an experienced radiologist know, okay, well,
Like false positives.
false positives. And so there's a lot of room for improvement. I'm not saying it's bad. I think AI is amazing, but it should be used in conjunction with a well experienced breast imaging expert. It can improve their accuracy, but it's not a replacement. And there's still a lot more room for improvement. So right now, we're just on the very, very beginning of it.
Yeah.
So imagine like being in a full self-driving car, like a Tesla, when the first full self-driving came out. It's basically having you put your hands on the steering wheel, like almost at every other stoplight, because
Yeah.
it can't do it 100% on its own. But as time
Yeah.
has gone on, it's gotten significantly better, and it
Yeah.
can pretty much drive on its own now. But it took years to get to that. And right now, we're at the very beginning of that AI for radiology. I think eventually it'll hopefully get there where it could basically just read everything perfectly, but it's far from that right now. And it's going to still take a lot more time. But in the meantime, it's a great tool to help the radiologist to be like, hey, also don't forget to look at this area and what about this area? And so it's good.
Like a second set of eyes.
It's like a second set of eyes, but it's not a replacement. It's just going to get better and better. And once it gets to a certain level, it's just going to be absolutely amazing. But we're not there yet.
Yeah. Makes sense. My last question for you is if you had one message for all the women listening out there right now, what would you want them to know?
I want women to know that be in charge of your own health. No one can make you do things or not make you do things. You're in charge of your own health. We have wonderful sources out there as far as screening programs, innovations, and medicine and healthcare to help everybody. You just have to be able to take advantage of that. Educate yourself. Know what your Tyrer-Cuzick score is. Know if you have dense breast. Know what tools are out there that can help you. Because the resources are here. We're here to help you. And like I just said, you're the CEO of your own health. And lastly, we talked about lifestyle modifications, and we use it in the context for breast imaging, but it applies for everything. Be healthy. Just common sense. Eating this organic grass-fed meat or whatever is probably better for you than this ultra processed food with artificial dyes and colors. Then yeah, that is probably going to long term be better for you. So try to just make healthy choices, exercise, eat healthy, abstain from things that you probably know are not good for you, like smoking and drinking. Stay active, stay fit, maintain an ideal body weight, not just for your breast, for your whole body and for your longevity as a whole.
Yeah. And also maintain a healthy mind
Healthy
and
mind.
healthy emotions because
And all
those
and all
play a role as well.
And all these things are so tightly intertwined
Yeah.
because if you feel good, you look good, you feel good,
Yeah.
it all just goes together. You're
Yeah.
healthy, you're active, you have a good mood, your mind, everything gets tied in together.
It's a lifestyle. These are little decisions and little choices that ultimately become a regimen and a routine, and then they become a lifestyle.
Yeah. Maybe a little tough at first, especially if you're not used to doing these things, but like anything, do baby steps and just work towards a goal.
So I like to end every episode with 3 questions that I ask every guest. And it's just meant to encourage a growth mindset. And it can be about your work or personal. And it's just there to help inspire others or maybe give them a different perspective. So I would like to ask them of you,
Sure.
what habit do you think everyone should try for 30 days?
Go to sleep early. For years, I was a night owl and I would stay up late, either doing projects around the house or watching a TV show or being on the internet or just doing random stuff. And since being married and now having a family,
You better catch up
uh,
on that sleep.
yeah, yeah. No, but I've gone into the routine of, going to bed much earlier, 9:30, 10 at night, and
Oh, sounds
instead of like,
delicious.
instead of like 1 in the morning.
Yeah.
And it's honestly made a huge difference. I feel, more energy throughout the day, feel
Yeah.
sharper. I get up earlier. I feel like I can get more done throughout the day, and I've wasted less time because of going to bed earlier.
It's so true. There's no pill, there's no regimen, there's
No,
nothing else
it's the
that beats
basics.
a good night's sleep. I mean, the nights I actually caught up on some sleep this weekend. I had
Yeah,
like 9 hours of sleep. I woke up, my skin looked fresh, I
yeah.
looked so good, no wrinkles,
No
like
bags, no dark
no
circles.
bags.
Yeah.
What is one belief you let go of that completely changed your life?
Oh, that's a tough one. One belief that I let go of,
And it can be work related or personal.
I think for me was I was such a perfectionist and kind of OCD. And I think honestly, I think a lot of doctors are OCD
Yeah.
or perfectionists.
Yeah.
It's just what makes a doctor. So I think as time has gone on, I've let go of just trying to have everything perfect around me. And it's caused less stress. And I'm like, you know what? I'm not going to stress about that. Okay, it's good enough. Good enough for me is like something like being 98% like good. That's good enough for me. It doesn't have to be 100%.
Yeah.
And so I've learned to let go of that. I'm like, not every thing has to be put away in my bedroom or living room before I go to bed or when I leave the house. It's okay. Little stuff. I know it sounds stupid.
No, I
You
I
know?
actually can relate to that. I'm the same way. I can be very type A, very OCD,
Yeah.
and I read the book, Don't Sweat the Small Stuff,
Yes.
and
Exactly.
I'm like, "Okay, the guy in front of me is driving super slow, and I'm so annoyed. It's fine." Or the sink is full of dishes tonight. I'm gonna go
Yeah.
to sleep, and it's fine. They'll be there in the morning. I'll wash them in the
Correct.
morning. Yeah, don't sweat the small stuff.
Yeah. And I think that once I got married, that became. I'm like, I just have to be more like that. I just have to let the small stuff go. And honestly, it's been great. I'm less stressed about stuff, which is
Yeah.
which is worked out well.
And lastly, what is one thing you want to do that you haven't done yet? And
Gosh.
again, it can be professional or personal.
Yeah, honestly, I feel very blessed. I feel like I've been able to do most of the things that I want to do. Um,
And
I'm
you
in the
just
process.
opened up your radiology center, so that's like
Yeah,
a
yeah, yeah. So that was a long-term goal of mine, and I did that. I think it has to do with traveling. I've traveled a decent amount, but there's still a lot more traveling I want to do.
what's number 1 on the bucket list?
Yeah, I want to travel the entire world. I want to go
Yeah,
explore more of the Middle East, Africa, Australia. There's a lot of places I've been to, but there's still a lot more that I wanna go and travel and see and learn about. I just love getting to see, different cultures and see what's normal for their way of life
yeah,
and how that, compares to how we are here, the good and the bad. And sometimes it's nice seeing how things are at a different place and gives you perspective of what you have here. And
absolutely.
so I never take anything for granted. And I think it's good to sometimes be mindful of how other people are right now in this exact time, what other people are going through, and gives you a new appreciative outlook in life.
I love traveling as well. It's one of my favorite things to really just talk to locals and
Yeah,
just kind of understand, like, their way of life,
exactly.
their education system, their healthcare system, their economy. I'm just so curious on how other people live their day-to-day lives because when you step out, I was just recently in Dubai. And when you step outside of your little bubble of LA or, we're in
Oh
Beverly
yeah.
Hills and we're in this little bubble, when you really just step outside of just any city that you're in, really, and you travel abroad and you realize that we're so small on this planet Earth. And we're really so lucky as well, living in the US, but we're so small and just giving you perspective, like you said, on other people's lifestyles. And it's really, I think, the best education
The best.
aside from a formal education.
Absolutely. No, I second that.
Do you have time to squeeze in a little baby moon? Because it doesn't sound like you're going to be doing much traveling.
Not on this round. Not on this round. But yeah, hopefully soon.
Okay, so tell us where people can find you.
So we are our first office was opened here in Beverly Hills on 99 La Cienega, and our second location that just opened up a few months ago is in Tarzana, right across the street from Providence Tarzana Hospital. So two convenient locations, one for our Valley people, one here on the west side, and so both state of the art women's imaging facilities, and we would
Is
love
there a
to have you there.
website?
Website, you can go to www.herimaging.com or www.premierwomen'simaging.com. Either one takes you to the same website. And come check us out. I think you'll be happy.
Amazing. Thank you so much. This
Of
was
course.
just so much information, and I'm sure that it's going to help a lot of women. So thank you so much for your
Of
time.
course. Thank you for raising awareness and having me on the show.
Thank you.
All right. Thank you.